All right, good afternoon, everyone, and welcome to the second 2023 seminar of the Centre of Research Excellence in the Prevention of Fall Injuries. Before we get going today, I'd like to start by acknowledging that I'm hosting this meeting on the lands of the Gadigal people of the Eora Nation, and I pay my respects to those that have cared and continue to care for this land. I celebrate the diversity of Aboriginal people and their culture, and I extend that respect to any Aboriginal and Torres Strait Islander people here today. So today we're very lucky to be having Professor Emeritus Lindy Clemson presenting to us on environmental interventions for preventing falls in older people living in the community. Lindy is an expert in public health research and ageing and an occupational therapist with a PhD in epidemiology. She's a fellow of the Occupational Therapy Australia Research Academy and a member of the University of Sydney School of Health Sciences, Faculty of Health and Medicine. So I'll hand over to Lindy to start her presentation. We'll reserve questions for the end of Lindy's presentation and have a good 20 minutes for discussion. And so then I'll stop sharing, Lindy, so that you can.
Thank you for inviting me today to present the findings of our Cochrane database of systematic reviews for environmental interventions and for preventing falls in older people residing in the community. If there are any OTs in the audience, this is for you, you amazing people. What you can do on just one or sometimes two home visits. For the non-occupational therapists, it will illustrate why this needs to be part of a multi-component fall prevention program. I would particularly at this point like to thank my two occupational therapy amazing trialists, Susie Stark from Washington University and Alison Pighills from now ex-UK but now in Australia, but also Kathy Sherrington. Thank you, Kathy. Without you, I could not have got this far. So, as many of you know, the Cochrane systematic reviews are the best evidence for trials and have very strict protocols. In our review, the primary outcome was the rate of falls, so the number of falls and the time in the study. The secondary outcomes were the risk of falling, that is the number of people. And we also had some pre-planned sub-analyses. So the work was done in terms of assessing and interpreting the evidence and the certainty of the evidence using the grade rating. So environmental interventions aim to reduce risk from their interaction with the physical environment and include single mode interventions such as assistive technologies or devices to the more complex adaptations to reduce fall hazards. So these were the three areas that we looked at. As I said, the home fall hazards, which I'll mainly concentrate on today, but I'll also give some a brief summary of the assistive technology outcomes, and we had one trial that looked at education. These were our questions for our home fall hazard interventions. Do they work? Who should we provide it for? What should the intervention look like? And who should deliver it? First of all, the question, does it work? I need to say that for those who are not familiar with forest plots, it's not that hard. Just stick with me if you can. I think quite a few people on the seminar today are familiar with these. But all you need to do is look for that big diamond down the bottom. But check which side it's on. And in all my slides today, the left-hand side of that line down the centre means that it's effective. And if that diamond or the line is on the far side, it's a significant intervention or result. So it does work. If you can, it's fully to the left of the line. And in fact, it shows that there's 26% less falls for those in the intervention compared to the control group, and this is a significant finding. There was, however, high variability among these studies, that we call statistical heterogeneity. And it's a consequence of either clinical or methodological diversity, or can be both. So to accept this as high certainty evidence, we needed to be able to plausibly explain this amount of variability. And the heterogeneity there is in that I-square statistic down there, which was quite high. So we really needed to look at our sub-analysis. And while I'm presenting the rate of falls in each of these, the risk of falling or the number of fallings were fairly similar. So this is our results of who to do it with. Risk of fall, and so we looked at those selected for high risk of falling at baseline and those not selected for high risk of falling at baseline. The top group are those that were selected for high risk. And there was a significant and strong 38% reduction in the number of falls for those selected at high risk at baseline. So these were people having been recently hospitalised and also had a fall in the past year and or functional decline. People who had multiple falls, those receiving aged care services and a history of fall in the community, or severe vision impairment. So it was high certainty evidence, and it also is an important message because it tells us who we should do this intervention with. Where is the best investment? And it's with those at risk older people. How to do it? So we wanted to understand a little bit about if the intervention was done differently, does it have more of an effect? So we looked at those assessments in this sub-analysis that at the top, those had higher tailoring of intervention to falls, and that those trials at the bottom were determined through our review process as having limited tailoring of intervention to falls. And we found that we can reduce falls by 31% when the aim of the visit, the assessment process and the intervention are highly tailored to falls. And how we determined that was back in 2008, our first meta-analysis. I forget how many studies we had in that, but it was certainly a lot less. That was with Jackie Close and Lynette McKenzie, and from the UK, Claire Ballinger. And we determined a list of criteria, such as whether they had a comprehensive and validated assessment of fall hazards, whether the risk assessment takes into consideration the functional capacity of the person within the context of the environment, and also adequate follow-up and support. Using those criteria, they had to meet 75% to have higher tailoring, and if not, we categorise them below. If we look at the 5 studies below, Day, Stevens, the top one Day and the bottom one Stevens, I think my head's in the road actually, they both have they're in the middle of the line, they have a big square, and that they were not effective. And those studies had a very small, they had a very limited list of checklist. The Stevens one were nurses going out with a very limited checklist of what they would look at. And the other ones were a mix of discharge planning, where the discharge planning was not the only focus. There were some full hazard assessments done, but they were either screening or not comprehensive. We wanted to know if there was any difference in the trials if delivered by different personnel, and we did find that the largest reduction of falls is more likely when the intervention is delivered by an occupational therapist. So at the top, this was significant, 32% less falls, and delivered by other personnel, it was different. We can now see the stronger effect when delivered by the OTs. The Big Hill study, this is Alison's study that she actually did in the UK. At the top, the sub-study of people there were delivered by occupational therapists, and it's completely over this side of the line and effective. And down below, these were the sub-study of people that was delivered by domiciliary workers. Now, Alison trained them both the same way, using quality criteria, so they were both trained in the same way. However, the occupational therapists were able to deliver a much better and significant result. So this is a quick snapshot of 3 highly tailored and quality interventions that reduce the rate of falls, and all with rigour of trial evidence. Interesting that each is a decade apart. The Cummings study we did in Australia, that was effective for a sub-study of people who had a fall in the past year. So the Cummings study mostly recruited people when they were in hospital, although the home visit was done afterwards. And in the table I've got the number of visits, a little bit about the evaluation, the follow-up, and then adherence at 12 months. The Pig Hill study, which is what I've spoken about already, they had a home visit, they used the Westmead Home Safety and an accompanying manual, joint problem-solving priority setting. This was the adherence here is reported for the OTs who delivered the program. In their study, the occupational therapists had about 3.6 recommendations, whereas the domiciliary workers had about 1.6 recommendations. So it was quite different, obviously, what they were delivering. And then the bottom study is by Susie Stark in the United States. And we were very pleased when this finally got published, because this was another important study and very recent one. In Susie's study, they did 2 visits and an optional extra visit. They did a very comprehensive assessment. Susie called it the HARP program. They also had a booster session. They had a very high adherence rate. Susie tends to work with people in St. Louis who are very low socioeconomic group and very often don't have much access to health. It's an interesting variation of the other studies and probably more intensive, but it's a very good study if you'd like to look that up to find more about it. So, in summary, we could say that home fall hazard reductions conducted on a home visit reduce the rate of falls and the number of people experiencing falls when the greatest effect is given to people at high risk of falling, high certainty evidence. We show greater reductions depending on the degree the intervention is tailored to falls, and they're more effective when delivered by an occupational therapist. So to identify an evidence program that works, it needs to include specific elements from the assessment in the home, education, a plan to remove or change hazards, or to help install changes. Why is who deliver so important? In Sarah's UK trial, Sarah Cochrane conducted a very large, actually it's the largest home safety trial, and it was only finished recently, and it was not effective. The vast majority of OTs questioned the criteria used to recruit participants in the trial, having either one previous fall in the past 12 months or a fear of falling. As trial participants were often poles apart in terms of functioning and demographics from the patients' clients that the OTs would have on their normal caseloads. So this was data that they collected from qualitative interviews with the occupational therapists on their OTIS trial. They described such trial participants as active and very able-bodied, with high standards of living in their home environments. So we actually, while this was a quality intervention that was delivered by occupational therapists, because it was such a large study, it seemed that they really worked hard at recruiting whoever they could, and that resulted really in people that the OTs felt that they weren't the usual people that they recruited. So we did not consider that to be high-risk people on the whole. There was a sub-analysis of their study that we included in the higher risk. So for those that were hospitalised recently, the effect, it was a significant effect, so in that sub-study of this trial. So the trial actually contributed to our second forest plot that I presented, showing the risk of falls. So we had one lot that had recently been hospitalised, and the others were just people in the community that they had recruited in some way. So who with is very important. Why would it be occupational therapists? So in the smaller numbers in the OT group, this is Alison Pighills in her study comparing the occupational therapists and the domiciliary workers. She made some observations in her publication, and she said the smaller number of falls in the OT group, she believed, could have been a result of greater safety through a combination of environmental and behavioural modifications. In addition, an enhanced understanding of the effect of the environment on function, or a problem-solving approach involving the participant in identifying hazards and prioritising actions, which constituted actually the fifth criterion in our criteria, but it's often was never reported it's usually not reported in the trials. And as we saw the slide between the number of recommendations, it was clear something was going on. So it's likely that intensity, including participant involvement, directly affects adherence. And we know that research has already demonstrated that participant involvement in decision-making enhances adherence to recommendations. So they were Alison's insights and her reflections that she published in that publication. So what does an occupational therapy intervention look like? This was a conceptual framework that we developed to better understand what goes on in this 1 or 2 home visits that goes on. And it was built upon those criteria that we worked on all those years ago, and developed a little bit with initially with Lynette here in Australia. And then I took it to Susie Stark overseas, and we then put it through a process of review, going to interviewing a number of research academics in this area. In the UK, we went to in America and in Europe, and we actually published the process of this in our review, in a scoping review to update the Westmead Home Safety Assessment back in 2020, and Susie's postdoc, Marianne Kegler-Vitis, actually led this paper, and we included the framework within that. So we tried to describe what goes on. So this is what we believe, that understanding the person and the fall experience is really important. Moving through the home environment, using a collaborative problem-solving approach for hazards and solutions. We really believe that what happens in this process, that people become more aware of their environments In fact, Bob Cummings' early trial in Australia, he asked me at the end of it, he said that falls were reduced at home, but also in the community. And he wondered what I thought of that. And to me, that seemed to make sense to me, that people would become more aware of their environment through this process. That we need a number of techniques and tools in order to identify the problems as well as what the solutions might be, and prioritising and action planning. Lifestyle checks, it's also an opportunity when someone's shuffling to talk about their ankle strength and their balance, and to check out other aspects of falls prevention. And OTs tell me that they don't see themselves just doing the environment. And there needs to be an action plan for change, an actual follow up. So as you can see, our framework has a lot more in it, but that's a bit of an overview of it. The framework was used to create this online training for home fall hazard interventions for OTs, which Alison and I put together some time ago now, and it's now available through the Falls Prevention and Healthy Ageing Network website and can be accessed from anywhere. So there are 6 interactive modules, and we use that framework really to plan the modules. And it includes a range of resources for assessing interventions and some case studies. And it was, as I said, based on the evidence from the expert review that we did. So just a snapshot of maybe some things that are useful to think about how the process goes. This is a case study really of a gentleman that had a fall on the steps to his shed out the back. And he was observed being cautious on these steps and avoiding his shed more often. The next part of the process is, why is it a problem? And so the occupational therapist and their partner worked through what they thought, and he said he's turning his head sometimes, feels unsteady, he feels he might fall on the steps to the shed, and also they talked about when it's wet it becomes quite slippery. So it was a matter of brainstorming between the 3 of them what might be done, and then they came up with 3 potential solutions: installing a handrail, non-slip strips, take particular care when climbing steps, a behavioural approach, or removing nearby shrubs causing the moss and causing the problem. Implementing identified solutions, do the quick fix on the spot. In all our trials we've always had a little bag of tricks, which is the non-slip strips and also the photosensitive lights, which we commonly use. Often falls prevention solutions can be actually really quite simple. But moving shrubs, who's going to do it? How will it be done, and who's going to do the follow-up? So it's identifying how that will be managed and then generalising the process. And that's a matter of really naming and framing what the change is and what the outcome will look like. And for these, and on this particular one case, he was observed that, so it was, if he can be observed using the rail, that moss was not forming and that process was happening, and he was raised his awareness and cautiousness level in other steps and generalising it to other areas. So what it does, I always talk about changing things around the home, better lighting, fastening loose mats. There's many things you can do with mats, contrast and visibility, and looking for things that you could improve. Some of the simple solutions, and then changing the way you do things. It might be slowing down, getting to that phone, avoiding clutter in places where you walk, and safe climbing. And yes, that lady standing on that stool, that is how she used to get up and reach for something. Lots of options there. And some of the tools can be really quite simple, but it's a matter of also changing habits. So techniques for behaviour change. I always say targeting the behaviour change. So in this situation, what is the target behaviour change? It's not not leaving your shoes there. It's actually finding a place to put the shoes so that you can solve the problem and following through with that. And then having a cue to remember to put your shoes in that particular place so that you're not going to trip over them at night. Getting back to the other studies, the other groups that we looked at, we wanted to know whether education as a single intervention was going to work. So there was only one study, and it was a non-significant finding with low certainty evidence, although they did improve falls. It was a very cute little study. It was in Japan, and they had a lecture, and they also used a mock-up of a Japanese home. So there's the mock-up, and it's 60 centimetres by 60 centimetres. And it's very cute. So it's kind of like a doll's house in a way. So the participants had to practice and change hazards in the home, pick them out, and maybe put a rail in somewhere or a light somewhere else. And they also had gave them a checklist to go home. But that's the only study that we had. We found that looked at education as a single intervention. Now we did have a fourth category, home modifications, as a standalone for task enablement and independence. We actually found no trials that fitted this category of intervention, but we believe that the home safety visit that focuses on falls prevention is very different than a usual home modifications home visit. We do actually, we do actually are waiting for one trial to be published at the moment, but it didn't make the review. So next time round, or interim reports, we will be able to present the results of that. So do we need to really focus on falls or not? Can we just do home modifications as we always have, as we have more traditionally done? And so our criteria for those interventions to be included in the home hazard category, they had to have something of those criteria in them for the 5 criteria that we were talking about before, that, you know, a comprehensive assessment, etc. And if they had even a screening tool for falls prevention, even though, you know, they may have been a post-discharge visit and they were looking at other things, not just falls prevention, then they could be included in our review. But we were able to handle that, to look at that more closely by looking at the tailoring, and that provided some evidence about the intensity or not of the intervention. But as I said, we did not find any home modification trials that actually had falls as an outcome that we were able to include at the time. So, assistive technologies and devices. This was divided into 3 areas: vision improvement, footwear and foot devices, and self-care assistive devices. The vision improvement, we did some pooling of the results, but the other 2 areas, the interventions were just too diverse, so in the review the results were presented in descriptive only. This is the result for the vision improvement studies. These are not recent studies, we've seen them previously, but in our review we were not able to make any conclusions from this because it was considered a practice point. However, these were the results for the risk of falls at baseline. So those were selected for high risk of falls at baseline are at the top, and at the bottom were those not selected for high risk of falls at baseline. If we look at the 2 studies up the top, Bob Cummings' study, the diamond, everything is on the right. The result of both together says there's no result, but they're very, very different here. There is, Bob's study is on the right. It was not significant. It actually increased falls, and they provided checked people's prescriptions and provided glasses for them. And on the left was the Harron study that looked at people with multifocals, and the risk factors here were quite different. So for the Cummings study, the higher risk were those that had a fall in the past year, and those below did not have a fall. There was no difference. For the Harron study, those people that were at risk were those who went outdoors more often, and that was effective for these people. And when the down below in the Harron study there, it's right in the middle of that line, and it didn't have an effect for those people who did not go out very often. So they were both large trials, and we really can make some practice points for that. So older people with a history of fall should be advised to take particular care when changing eye prescriptions as a result of the Cummings study. And the Harron study, older people who use multifocals should be careful on steps and other changes or level, or have 2 pairs of glasses. Some very useful information came out of those. Then we have footwear and foot devices. There are few trials that looked at these were low certainty evidence of little or no effect. So there were changes to footwear or inserts or whatever like that. The McKinnon study was one that was effective. It was a small study, but looked at an overshoe device in winter icy conditions was effective. And that's actually the little thing you put over your shoe there that they looked at that stops you falling over in icy conditions. Not so frequently used in Australia. And the other one was a couple of odd trials that couldn't really be compared together, but they were low certainty evidence of them. The Thomas study was a cute little one. In this study, they looked at whether people so it was a randomised trial of 3 arms, and they have people who were on the waiting list for Meals on Wheels. And one arm they gave meals delivered daily, and the other arm they gave frozen meals once a week. And the people that got meals delivered daily were actually showed a reduction of falls, and there was no reduction in the people who got the frozen food. So maybe better nutrition is the way we need to go, and a friendly face bringing our meal around every day. A 2018 Cochrane review on multifactorial and multi-component interventions preventing falls in community residing older people by Hopewell and colleagues provided evidence that multi-component interventions are effective in reducing the rate of falls, and this was considered moderate certainty evidence. In addition to exercise, the components should include home and community safety and fall prevention education. 6 trials were included in their rate of falls analysis, which showed a 26% reduction of falls, and it was significant. And in 11 trials looked at risk of falling with a relative risk of 0.82, so a reduction of 18%. Our Environment and Falls review did not include any falls in public places or away from the home, but that's really because we found no trials that looked at this as a single focus. If people ask about fall prevention strategies around community mobility, I usually refer them to the Stepping On Manual, which is one of these multi-component programs for falls prevention. And we have quite a good practical section there on community mobility and safety, which could be useful in other contexts as well. So I think that was worth mentioning. There's also been a couple of pilot studies that I'm aware of they have not managed to get any full-time large funding for a major trial yet. But Sarah Santon in the US has combined the life embedded exercise program with home safety and with occupational therapists running that intervention, and that's had some really nice effects from their pilot study. But sadly, for a few years, she hasn't managed to pull off the big grant. And Timothy Kuo in Hong Kong did a study also looking at life and home safety delivered in people's homes. He actually only got 100 people or so on that trial, so they didn't end up getting their quota of their target. And I asked Timothy, was that because of COVID? And he said, no, it was because Lily, the OT, fell pregnant. And I thought, oh, that wasn't a very good succession plan. But anyway, they're going to write the trial up as a pilot. So there are lots of opportunities, I think. And I'm just citing those two because I'm an occupational therapist and I'm aware of those two trials. But the multi-component review back in 2018 certainly highlighted the opportunities for combining different components. We all know that exercise is so incredibly important, but with people more at risk, it may be advantageous to add other components. So what's next? A home visit, home fall hazard publication that is user-friendly. We have plans to do one, the Cochrane review of all of its 90 pages or whatever, and it's very hard to read for everybody, so we're very keen to get one out that brings this out and is more accessible to the people. So part of the plan for this year, we hope. And also we're very pleased that our review came out in time to be included in the Australian Fall Prevention Guidelines update, which is coming soon. And just a reminder, if you are interested in learning how to do a home hazard intervention, there is an online workshop. There are lots of resources there as well that you can just download: assessments, list of strategy solutions, the action plan template that we actually developed more for the eye-focused dementia study actually, but it's a really useful template, and various case studies. So there's the 6 modules as well as that, the resources that you can just access. And just to mention Susie Stark's work, the HARP study, the Home Hazard Removal Program that she did, the latest publication to come out that was effective, that she has a manual available, and there's her website. So she is going to do some training as well. If you'd like to go over to the States and meet Susie, you can keep watching that website. So that's it for me today. So thank you for your attention, and I would be happy to join a discussion and answer questions now.
Wonderful. Thank you so much, Lindy. Such an enormous amount covered, and always uplifting when there's really strong evidence something really does work. We can reduce falls in some ways. So thank you. So we'll open up to the floor. If anyone has questions, you can kind of raise your hand or just yell out, or I'll monitor the chat as well. Rick, ready to kick us off. Thank you.
I'm in a question asking mood today. Sorry, everybody. Lindy, I think this is really excellent work, and I was wondering what opportunities you have to share this information directly to the aged care industries, because from my opinion, OTs are often forgotten when it comes to and you've got the evidence to show the value. I hope you've done lots of spruiking.
Yes, Rick, I've been spruiking now for many decades. Happy for my colleagues or I to present anywhere of this. It is tricky, isn't it, getting the message out there? Any ideas you have would be very welcome. Publications aren't always looked at. Trying to get maybe some information. Maybe we should do a few things in some of the aged care little magazines that they have. any other suggestions, look, we're happy to run with.
And the new act, the aged care industry representative group does a big conference in the middle of the year. That would be a great opportunity to share your work.
Sure, yeah, if you let me know, that'd be fine.
And one more.
I'll fit it into my retirement activities.
And with the new quality indicators that are coming into home care, I was just trying to do a quick Google. They were supposed to start in April 1 this year. Does anyone know what the new quality indicators for home care? Because I assume falls would be one of them, but maybe it's not.
I don't know.
Okay.
Something to follow up on.
Yeah, in your retirement.
In my retirement. Oh, I'll get someone else to do it. Better still. Thanks, Rick.
All righty, Terry. So you've got a question there.
Thank you so much, Lindy, not only for sharing that today, but also for the volume of work that you've contributed to that evidence base that you've synthesised over the years. Lindy, I've always been vexed by that concurrency of the OT home visit style intervention that has both environmental changes, but also that educational element. One of the things that I've always wondered is, how much is it column A, how much is column B? But then again, does it really matter? If you've got the person going out there, you wouldn't ever say to an OT, don't just focus on the education or just the environment. Still have that very naturalistic interaction with the patient. I was wondering if you had any thoughts or comments as to the relative contribution of the actual environment versus the behavioural, the educational elements that have been involved in a number of the studies.
Yeah, look, I think that whole, and what we don't usually report on is that problem-solving approach. And I guess that's where OTs are trained. We just do that anyway. But when we focus on falls, then we're starting off from understanding the person's perspective. And so, these interventions are tailored. That's the thing, whether it's exercise or the home visit, you're tailoring it to the person. So I think that it's a combination. I can't separate when you're looking at a problem with someone. You're observing it in the context of how they perform that. So the solutions, and sometimes it is purely an environmental solution that you're looking at. But, like in that example with the guy at the shed, it was a combination of things. And in all of that, you're raising his awareness so that of how he moves into the shed. So, it can be, it's tricky. And I don't think we've ever done any studies to look at separating those. And I think the best way you can look at it is in the studies where people have just gone and made the changes and they've been limited lists, they're not relevant to the person's actual, we know going into a home, it's a combination of the person's mobility and their functional capacity. It's that interaction between the environment and the person. So that's kind of the area that you work in. I don't know if that answers your questions at all.
I guess by extension of that, though, Lindy, if it's the straight environmental change that's not particularly targeted at the individual that you think is probably not doing that much, do you think there's much benefit in trying to pursue like universal gold design standards for housing development, that sort of thing? Or do you think there'll always be a need for that individual tailoring?
Look, you've got to have that individual tailoring in something like this. Universal design makes it universal for everyone, but it doesn't help the person with a particular disability that needs something different. So universal design is useful to make it accessible as possible, but it's not going to cope with individual need. No, is my answer.
Right, Richard's made a very interesting point in the chat that Blacktown acute aged care department's down to just 2 OTs for 56 patients, and it appears that the problem's really the lack of personnel. So people aren't applying for the jobs, which I was reflecting that even in my time, when I've been working on the inpatient wards, even with what was fully staffed OTs, it certainly was very rare that as part of their routine care, home visit was not part of routine care for OTs in acute wards. So yeah, I'd love to hear your thoughts, Lindy, on both those points.
Yeah, so first of all, acute care wards and OTs not doing home visits. It's probably not appropriate to do a home visit on everyone in an acute care ward. But, we're saying if someone really has functional decline and had a fall in the past year, then maybe it's worthwhile refer them to community OT to follow up when they are home, which is probably the time, doing a discharge visit can sometimes, when you do discharge visits, if you're looking at getting in and out of the house and the bathroom and things like that, you're looking at short-term solutions to things where the person's at the moment. So you're really not looking at that whole, falls prevention thing. So I guess that, I did this interview many years ago on Westmead Hospital. I asked to interview people who had not followed through with fall prevention interventions. And I did some lovely little interviews just many years ago, and we wrote them up. And this one particular lady, she'd been in hospital, she'd had a fall, and the OT had gone out and worked at the bathroom and fixed up the bathroom. That was the focus. She needed to get and have a shower and arouse somewhere else. So that was what they fixed up. But when I spoke to her, her falls had occurred outside at train stations, on steps and stairs. And this was a lady who had lived on her own. Her daughter was living with her, but her husband had died many years ago, and she did all the house maintenance. In a month's time, she was going to get that ladder and clean the gutters out of the leaves out of the gutter. Now, that should have been the focus of home safety for her, is safe climbing or getting someone else to do those tasks. So I think that it's difficult on, if you are able to do discharge home visits, if the focus really is on a lot of things to get you home and so on, that's really good. That's what you need to do there. And you can start that falls prevention, but maybe that falls prevention home visit needs to actually go just a little bit after that as well. So it just depends on that focus. In terms of not a lack of personnel applying for the vacancies, that's not good, is it? I have no idea on how many OTs are out there or looking for work. It seems surprising to me that with all our universities, we aren't producing enough OTs. I don't have an answer for that one. Charlotte, was there anything else you wanted? I'm sorry, Richard, did I answer your question at all?
Thanks, Lindy. I think it's just a great example of translation, isn't it? We've got the evidence, but we've got another problem in the system, and unemployment is almost at a record low in Australia, and even advertising for jobs elsewhere at the university, we're not getting many applications. So it's a very, very tight jobs market, and our poor OTs, they actually said to me yesterday, that there's no point going on the community waiting list. You'll never be seen. So we are a bit stuck. When I first started in geriatric medicine some time ago, we did a lot of home visits, and it's very rare now. And one consequence of this, which is very, very interesting, is that our young therapy team sometimes don't have a good idea of what normal can be at home, and I worry sometimes that they've got a professional, well-off middle-class view of what a home should look like, and half the homes in Blacktown don't look like that. And they say you can't go back there. Well, tough. 10,000 people are living in similar situations. That's the reality. So I think there's another problem of not doing home visits, and that's not knowing what's in your patch and what is normal, what is usual.
And Richard, I know it's such a fabulous place to work where you work out at Blacktown, where I worked for some time. I'd love to advocate that as a great place to work. But yeah, look, we know that, you know, and the caseload problem for physios and OTs is real. But and when you do have the staff, I guess it's a matter of making sure if you can offer an evidence-based intervention, like look at, you know, who you should be seeing. There's all sorts of answers that I guess in some way, but yeah, it's tricky. I wonder in terms of trying to attract OTs. Yeah, I don't know the answer to that one, Richard, at all.
Well, if anyone knows of an OT wanting a job, just get them to contact me. I'll put them in touch with the right people.
And I can vouch for what a great place it was to work in.
The new facilities are the best I've ever worked in my career. So, you know, the physical facilities are fabulous. But you get into a death spiral if people are so short of staff that the workload is terrible. You sometimes can't get out of that spiral very easily.
And interesting you say that the professional comes from a middle class background and has no idea of different places. I guess that working in that area, you do get to understand how, you know, so it becomes when you work and do home visits in a local community, like I did around Blacktown, Mount Druitt and places like that, you get to understand the community and have a real respect for that. And so that just comes with experience. I do always like to, when I'm talking to OTs and others, show some of the slides from actually Lily, the OT in Hong Kong, who did that study on home safety and the LIFE program. Some of her slides of the homes in Hong Kong have got nothing over the ones in some of the lower socioeconomic Australian communities. They were so tiny, they had no cupboards, the clutter was in the hallway. The lady got up on the washing machine to pull in. Have you been to Hong Kong where your washing's out the
yeah, out the window?
So the lady was hopping up with all her frailty, hopping up on the washing machine and pulling that in from outside to pull, you know. So the OTs there that come from middle class also have the same thing when they need to go out and really understand the issues. The challenges there were a lot different. So the answers and solutions were different and needed to be from experience. So you need a lot of tools in that toolbox when you start to learn about that. Yeah.
Okay, insights. Thank you, Lindy and Richard. Yeah, I heard a segment, ABC Radio had a segment the other day of just things community health professionals see in the home. So I very much agree with that. Kathy, you had a question or comment.
Yeah, I think just a reflection that I think we've all come to realise that, you know, gone are the days that as researchers we can just be kind of generating research and then sitting back and hoping that someone's going to put it into practice. So I think, you know, your talk is just such a fabulous example of, you know, such an evidence-based area. And then the things that Richard and Vasi are saying is, you know, the disconnect between, you know, what's actually happening in practice. And so I think we need to continue to work on ways that we can kind of disseminate that information and sort of actively advocate for, you know, more funding for these types of interventions. And yeah, perhaps we can learn from others in, you know, some of the ways of kind of synthesizing and disseminating evidence. So both Megan and Marina, on behalf of the CRE, are involved with CRE, which is a kind of group linking various prevention CREs. And some of those people are kind of much better at the disseminating evidence and advocacy than we are. So yeah, I think we need to step up our efforts collectively in that department, and probably there's role for kind of ongoing training as well. So yeah, I guess that's let's continue to try and work together to make a difference.
Yeah. Thank you, Kathy.
There any other questions for our last couple of minutes? If not, I feel like that's a very good note to wrap up on, Kathy. And yes, we'll just extend our deepest thanks, Lindy, for sharing so much knowledge and insights. And thank you, everyone, for the discussion too. It always contributes to a wonderful session. I wish you all a great afternoon. And bye for now.